All right, good evening, everybody. Here we are, part number 3 of the AEMT Transition Protocol Update 2020. After we are done here, you'll have another quiz, and at that point, you complete this, we'll be able to go ahead and schedule you for your skills update. So again, what are we going to cover in this session will be indications for ALS use, as well as the various new protocols, touching on them a little bit with some insight onto them. So, review indications for calling for an ALS paramedic, 2010I, which is a new protocol. And then we're going to look at the 20 separate signs and symptoms in which a paramedic level should be responding to your call. So A, altered level of consciousness, except in the cases where it's an apparent hypoglycemic or opioid overdose that may be managed by the IALS provider with that. And again, that could be fixed with D10, D50, depending on your service and what they utilize, as well as utilization with your opioid drug. Which in our case is naloxone, Narcan, giving that whether it is via IV or intranasal. Please remember, along with all of these, as we go through, proper documentation and contacting of medical direction is expected with each call to explain to the physician. Even if a patient is given D10 or Narcan, please remember you must contact your medical director, medical command physician to discuss the patient and have them notified, and then have the patient sign all appropriate paperwork. And if you have family and or law enforcement that's willing to double sign for that, you should also have that as well. The second indication for ALS backup would be allergic reaction to a medication or bite with difficulty breathing or swallowing, i.e. an anaphylactic reaction, any altered level of consciousness, or known previous reaction to highs within 5 minutes of exposure with that. Anybody experiencing cardiac symptoms, and that could be of a great breath, not just chest pain, but chest pain with shortness of breath, chest pressure, shortness of breath that goes along with any type of, say, upper abdominal discomfort, pre-existing syncopal episode that led to that or something like that. So when you think about cardiac symptoms, just don't limit it to, oh, the patient's having chest pain. There's other things that go along with it. And if you assess your patient as you're waiting for the paramedic response to come, you'll have a better idea of your diagnosis or your differential diagnosis during that. Cardiac arrest. E kind of goes along with A, the altered mental status, level of consciousness, along with the diabetic problem. Everything I said regarding A also holds true. Multi-system trauma or a severe single system trauma. OBGYN, anybody that is in their female that is in their second or third trimester with bleeding or miscarriage, that should be assisted with ALS. Any overdose or poisoning that's associated with any of the other categories on the list, whether it be CO or some wayward toxin that you're unaware of, that should be have an ALS backup. Respiratory distress, respiratory arrest, seizures, convulsions, any entrapment with injuries, unless they are obviously minor injuries. Now again, that's going to fall back on your assessment skills to find out what is minor or not. But again, utilizing your assessment abilities, mechanism of injury, and nature of injuries will allow you to make that determination. Any patient that has an obvious severe blood loss, anybody that is suffering from shock or hypoperfusion. Remember, shock is defined as inadequate tissue perfusion, and there are many, many reasons that patients can be diagnosed with being in shock. So please realize that. O, we have stroke or CVA symptoms, cerebral vascular accident, in that manner, headache, lightheadedness, hypertension, those things. All right. Syncope, patients that have fainted. Also, please remember that syncope can lead to other things, and the reason for the actual syncope needs to be evaluated. Did they have a cardiac issue? Were they hypoglycemic that led to the syncopal episode. So there's more than one concept here working. Any patient with unconsciousness, but again, that doesn't mean that you respond to the local nursing home. And again, you have a patient, staff says patient won't wake up. You go and you wake them up. They're like, I was sleeping, or they had taken a sleeping pill 3 hours before they were supposed to had waken up. So there's something to, again, as you assess that, please be mindful. But again, according to the protocol, any unconsciousness, patient complaining of severe pain anywhere, patients that are experiencing any type of excited delirium. If you end up having to utilize restraints for your patient to protect yourself as well as to protect the patient from injuring themselves or fighting against any restraints without them being aware of their actions, you need ALS care for that patient. And then T is basically a catch-all where if you have a patient with vital signs that are outside of the normal range, giving these parameters, if you have a patient that does not follow commands, if they have a motor GCS less than 5, a systolic blood pressure that is less than 90, a pulse that is less than 60 or greater than 120 or irregular. Number 4 will be respirations less than 10 or greater than 35 a minute or irregular. And with pediatric patients, vital signs that are outside of the normal range per your statewide BLS protocol, pediatric vital signs, which you can find in your protocol book under Appendix G. So getting into the actual protocols here, this is the general cardiac arrest protocol for an update 3031 IA updated. Please note that you get your IO IV access as soon as possible. You give your epinephrines in your 0.1 milligram per milliliter dosing. You'll end up giving 1 milligram in 10 mLs. All right, you give that every 3 to 5 minutes. Have somebody keep notes for you. Use a Sharpie to write on the outside of the box when you gave it, or you can just hit your operations button on your monitor of choice. That will allow you to timestamp when you do things. All right. Also, during this time, if you do get ROSC, remember to obtain and transmit the 12-lead EKG. If you are in a VFib VTAC, you'll hit record and be able to submit that as well as a pre and post. But again, it's very important as you're transmitting this individual to get that 12-lead. All right. You don't need to check glucose when there is CPR being going on. After the fact, maybe, but not actually doing CPR as it's not appropriate. Please remember that do not interrupt CPR to package or transport your patient. All right. High quality CPR is the most important thing that you could do. Remember, high quality 100 to 120 times a minute. Pit crew CPR, keep it going, keep it going. And if your ALS is going to be less than 20 minutes in arrival, you should consider awaiting arrival of that ALS practitioner. All right, so be mindful with that. Also, when we ventilate, if during those initial cycles of compression, if you have less than 3 providers, don't worry about ventilating the patient. Once you do get those 3 providers in there, and you get your IO high quality CPR, make sure you defibrillate as needed. Allow the AED to defibrillate. Okay, you put 1 ventilation every 10 compressions. All right, once you get the iGel in or your King airway, then you continue as your protocol dictates. General cardiac arrest here with the pediatric update 3031 IP. Again, please remember, do not interrupt CPR to package and transport. Consider awaiting arrival of ALS if ALS ETA is less than 20 minutes. High quality CPR, again, very, very, very important. Now with your cardiac arrest patients, please remember to use your pediatric dosing chart. Okay, 0.1 milligram per ml for cardiac arrest. So going to the appendix or having your PD wheel or having a Broslow tape or your hand tevi or whatever it is might be that you utilize your service approved pediatric device, please make sure that you're utilizing that for your pediatric dosing. Please remember, IVIO in a pediatric patient, getting IVIO is limited to the fact that if you only have enough help for high quality CPR. All right, based on the dosing chart every 3 to 5 minutes as we've already discussed. Allergic reaction will be 4011 I. If your patient is experiencing, it's one of these yes-no algorithms. If you have respiratory distress or wheezing or hypertension, blood pressure is less than 90, okay, you go down the yes. Is your patient adult or pediatric? If you go down the adult side, you end up seeing that you have your IM medication for epinephrine, which is your 1 milligram per ml, comes from a vial or an ampule. It is 0.3 milligrams in IM. Remember, that is IM. You're not permitted to give epinephrine in any way, shape, or form via IV unless it is during a cardiac arrest. So please realize this. This is an IM injection. Once you get that, you go ahead start your IV or IO. If your systolic BP is less than 90, give 1,000 mLs wide open. But once you start flowing fluids, please remember to get pre and post fluid challenge lung sounds. After that, as you continue to go through, you get that IV. Go ahead and give 50 milligrams of diphenhydramine and Benadryl. In that, if you're wheezing, if your patient is wheezing, again, you're listening to your lungs very intently. Pre-IV fluid in your primary assessment as well. If you are wheezing, give a nebulized bronchodilator, and as you can see, your bronchodilator options here are the albuterol or the albuterol ipratropium bromide combination, also known as the Duoneb. Go ahead and give that notice that they have removed out of here the half dose that is less than or equal to 14 years of age. So just go ahead with your full Duoneb dosing. If you get to that point and you need to talk to command, call command. Find out if they want you to do another bronchodilator or something of that nature. But call command with a full report. If you go down the pediatric side on here, all right, epinephrine. Again, it is still the IM dosing, but you need to refer to the pediatric dosing chart based on age and weight for that. Then initiate an IV or IO if needed, and then some math required. If your systolic blood pressure is less than 70 plus the age times 2, you go ahead and give a fluid challenge of 20 milliliters per kilogram and do that wide open, which should take about 5 to 10 minutes to go in, especially with a small bore catheter. But again, that's going to be your minimum. Okay, if it is above that, then you're okay. But just keep mindful of what that minimum blood pressure is on the systolic side. And again, basically, if you have a 5-year-old, if we were just to show you that that is a potential 5-year-old, 5 times 2, that would be 10. 70 plus 10 would then equal 80. So now if your blood pressure is less than 80, systolic is less than 80, then you would go ahead and give your 20 mLs per kilo. So again, a 5-year-old, you have to figure out how much they weigh, convert that over to kilograms, and give the approximate dosage. And that fluid challenge or fluid bolus is again given over a 5 to 10 minute time frame. Again, as you start to work your way through here, diphenhydramine, look at your dosing chart, give that via the IV or IO route. Okay, and again, alternately, if you do have wheezing, go ahead and give bronchodilator options. Now, please realize, okay, as you're working through this protocol, as you're working down here, it is a flow chart. But please realize that if you're stuck, can't get an IV or an IO, you can, if you think you're going to go through this, go back and give them the bronchodilator. They can always breathe easier with that as you're working. So these can be done, this can be brought up here, okay, and you can simultaneously give that. Just you don't have to do epi, IV, diphenhydramine, then that. But please remember, contact medical command. You're utilizing the protocol at 4011. Document it well. The patient was having some respiratory issues, some wheezing. Gave them the albuterol first while I was trying to get the IV, because again, an IV on a pediatric patient can take time. It's a respiratory issue with this, so you get that work on it, that can help. So please realize that. Okay, now if there's specific numbers next to something, you do have to follow that in a stepwise flow, but in this, anything above that contact medical line can be initiated as needed, whatever's easier. Again, pediatric patient, adult patient, yeah, I'm working down the allergic reaction, but you know what? You're wheezing. I'm not going to wait 10 minutes until I can get this IV in. Let's get this started. Your EMT can assist you with filling that while you administer it. All right. Now, if your patient is not having any wheezing or hypotension, initiate an IV for moderate reactions, and then go ahead and give them the oral diphenhydramine. Okay, and then follow your chart for that. If you do carry your oral diphenhydramine, and then contact medical command. Let them know they're coming. But again, with this as down the road, if it's a bad one, you should have ALS coming to back you up as it is. 4022I, your asthma COPD protocol. Please remember, initiate your IV-IO normal saline, but also remember that you may not administer epinephrine by IV or IO routes unless your patient is in cardiac arrest. So please be mindful of that. So when we have our asthma protocol here at COPD, you go ahead and look at your bronchodilators, okay, whether it is straight albuterol or you give your duodenum. All right. Please remember on your duodenums, as we've talked about in the other section, that needs to be run at about 6 to 10 liters per minute to get full nebulization of the medication. All right. Now, when we have a patient suffering from croup or stridor, okay, you would utilize this protocol, 4023IP. Okay, so these cases are when you believe that the patient where the epiglottitis is not suspected. All right. These patients might present with a toxic appearance, high fever, drooling, tripod position, and severe respiratory distress. If epiglottitis is suspected, minimize agitation and transport the patient as quickly as possible. But also that comes in the fact where how are you going to transport that child? Please remember, it is not safe and nor are you permitted to transport a child on the stretcher on mom's lap or dad's lap. Baby needs to be secured onto the stretcher utilizing a PD mate, an ACR, some type of commercial restraining device that allows transport. Or if you don't have one of those available, or mom meets you somewhere and the baby's in a car seat, please learn how to secure the car seat to the stretcher. Please remember, children are not supposed to be strapped into the bench seats sideways. They need to be on the stretcher appropriately. Mom can certainly sit there onto the bench seat or in the captain's chair and secure it appropriately, but baby and everybody needs to be on the stretcher for that appropriately, utilizing one of those transport style devices. In these cases with croup or stridor, you're going to administer nebulized epinephrine as we had talked about previously. You can either use your, if you do carry your epinephrine in the racemic version, it's 0.5 and 2 mLs of normal saline if it's available. If not, you can certainly use your epinephrine in the ampule or the unit at 1 milligram per ml. All right, using a if it is an ampule, snapping the top off using a filter needle, put that into your nebulizer, and then on top of that put approximately 5 mLs of normal saline, and then allow the child to nebulize that, whether if by blow by or giving them the nebulized pipe. So be mindful of that. Now, if you also do have lung sounds going on with this, a wheezing, expiratory wheeze, once you're done giving the epinephrine, then go ahead and utilize a bronchodilator. In this case, as we've previously discussed, using straight albuterol or the duodenum. But please remember, okay, get the epinephrine, the nebulized epinephrine, going first in that manner. Now, it says here, transport, minimize agitation, transport. Please remember that these children will respond better outside to a cooler environment. Also, please avoid running lights and sirens in these cases because the child more than likely will become extremely excited, and with croup and stridor, that can actually lead to a detrimental reaction to the child. Also, don't forget, your ALS should be coming in on the backup on this one as well. All right. Cardiac symptoms, 5001I, as we're looking at this suspected coronary syndrome, okay, O2 administer 95 to 99 via various methods. Put them on a pulse ox. Okay, make sure you administer aspirin 324 milligrams PO chewed. Okay, if they're allergic to aspirin, then you want to be mindful of that. But again, we're finding out that aspirin is not a bad thing to give patients. Okay, so give them the 481 milligrams. Chewed, it works best when chewed with that. But again, if they end up having some type of gastric issue, where they tell you they're allergic to aspirin, then reconsider it. Then if your patient has a systolic pressure of greater than 100, you want to make sure you get an IV normal saline, obtain your 12 lead, transmit it to your receiving facility, and then if your patient is not using a Viagra type drug, and again, when we say Viagra type drug, it is a erectile dysfunction drug. And if you look over here to remind you, ED drugs or erectile dysfunction drugs are your Avanafils, your Sildenafils, your Tadafils, or your Vardenafils. You know, Stendra, Viagra, Cialis, Levitra, Staxins. Okay, phosphodiesterase. These are all ED drugs. Now, again, this problem has always been focused on the male, on whether or not they're taking erectile dysfunction drugs. Please remember, erectile dysfunction drugs are not just limited to older individuals. There are younger individuals out there that may be taking it for medical reasons, or they may end up be taking it for fun. So please be mindful of that. Now, there is another class of drugs out there. They are the same drugs, but they're utilized for different reasons. So please be mindful. If you see the names of Rivato, Adcurcias, or the Sildenafils, or the Tadalafils, okay, ask your patient if they've ever been diagnosed with pulmonary hypertension, male and female, because you may be giving a nitroglycerin to somebody that is taking these drugs, but since you didn't ask them or didn't identify them early, you're giving a nitroglycerin to the same drug that is, we've told you for years, is dangerous in the form of an erectile dysfunction drug. So please read up on that, find out what pulmonary hypertension is and how it's being treated with that. If you are clear in that area and you're able to give nitro, go ahead and give your 0.4 milligram sublingual nitroglycerin, and you can repeat that up to 3 times. As you're doing that, you're waiting for ALS to come in, contact medical command and see if they want you to do anything more. If your pressure is not greater than 100 millimeters of mercury, initiate an IV, do a 12 lead, and send it to the facility, and then talk to the doc. That is your best case scenario. Please note, if the STEMI down here, if your STEMI is identified by the device that you're using and medical command cannot be contacted, transport to the closest STEMI capable receiving facility that's able to do PCI within 45 minutes. And then, as we've said earlier with ALS interventions, please try to intercept with ALS en route to the receiving facility. All right. If you ever have any questions, contact medical command. But again, good documentation, good assessment will help lead you down the right way on what you need to do. Narcan, ultra level consciousness, opiate overdose 7002 IA. Remember, our Narcan, if we're going to give it via intranasal, intramuscular, IV, or IO, we're given 2 milligrams at a time. And we're slowly giving this. We are not pushing this very quickly. Okay, you may also utilize a pre-filled 4 milligrams IN intranasal. Remember, that's a one shot. You can't split it between nostrils. You have to give 4 milligrams intranasal in one nostril. If you're giving 2 milligrams, whether it's if you're giving it IN, 1 milligram up one nostril, 1 milligram up the other nostril. Okay, please remember, administration of Narcan is not to wake them up. Because when they do wake up, they become extremely nauseated, they become ready to vomit, as well as they also wake up very, very angry. which leads to a potential injury for not only you, but also for your patient. So please be mindful with that. Our goal when administering Narcan, okay, in those cases of narcotic overdose, is to have that patient breathe adequately. Please remember, ventilating a patient is a good thing. So if you give your Narcan or start ventilating them. With that, please remember, Narcan does nothing to the cardiovascular system. Neither does your opioids in most cases. It affects the respiratory center. So when we give our Narcan, okay, we give it nice and easy, and we help our patient get better. We don't push this very, very fast, because again, as I said, that's going to cause problems with your patient down the road. Okay, you may repeat this dosing after 2 to 4 minutes, but again, if they are not breathing or not adequately breathing, please support their respiratory system with adequate ventilation, with BVM, with supplemental O2 as well. Also, with these patients, altered level conscious opiate overdoses, where you are giving Narcan, please make sure that you have suction available to you and be able to make use of that. Okay, also with this, a good source of airway control is also the utilization of nasopharyngeal airways, and properly measured as well as properly inserted can make your day and your patient's day much better as you're attempting to sequester the opioid overdose. So non-traumatic pain management, this is new. It's 7003I, and the criteria for this is patients who have a headache that is similar to previous migraines, not new onset, not the thunderclaps, no trauma related, okay, but a headache that's similar to previous, and they would have a previous history of migraines. They end up taking migraine style headaches. All right. B, patients with flank pain that is indicative of a potential kidney stone, and patient with acute pelvic pain. These are the criteria to which you can apply your non-traumatic pain protocol. Now, exclusion criteria, meaning don't utilize this non-traumatic pain management. Patients that are excluded are not considered for this. So, A, your patient has a headache that is new for the patient, that might be associated with a cerebral aneurysm, or it is their worst headache of the patient's life. They also may be associated with intracranial hemorrhage. Okay, known or suspected bleeding, a GI bleed, a leaking AAA, vag bleeding, or anything else like that. Anybody with unknown abdominal pain, known or suspected pregnancy, any pain from musculoskeletal trauma, those actually fall into the musculoskeletal trauma protocol 6003I, or if these individuals have a known history of glucose 6-phosphate dehydroxygenase or G6PD deficiencies. All right, so what is G6PD? G6 is a condition that's known to break down red blood cells in response to certain medications, infections, and or stressors. Now, G6PD is usually an inherited condition that occurs more usually in male, and it's more common in those of African and Mediterranean descent. Triggers for these problems are usually infections, stress, fava beans, aspirin, and other drugs. Okay, and when they're triggered, they include fever, dark urine, abdominal and back pain, fatigue, and pale skin. Most people do recover in a few days from this, but more than 200,000 U.S. cases per year are out there. Okay, so just be mindful, ask a little bit, talk to your patient if you are considering this protocol. Okay, if they have a history of glucose 6-phosphate dehydrogenase or G6PD deficiency. Non-traumatic pain medicine, again, as we look down at this one, note acetaminophen is contraindicated in patients with liver disease and or failure. So please note that. Don't give them oral acetaminophen in those cases. Okay. NSAIDs, your non-steroid anti-inflammatory destructions, include your ibuprofen and ketorolac or the Toradol, are contraindicated if they're taking oral NSAIDs within the last 6 hours, they have GI, vascular, or other suspected bleeding, or they have known kidney disease failure or a kidney transplant. We don't want to do that. Please remember, if you are going to do have a service that administers nitrous oxide, again, that's self-administered breathing. Please note intravascular or intraosseous access is not required for that. Okay, nitrous is self-administered. Okay, you document when they started and they document when they finished, and they must be maintain it themselves. You cannot hold it there for them. They have to be able to self-administer that. All right, so avoid utilization of nitrous in these cases. If you have a systolic blood pressure in a pediatric that's less than 90, and then the minimum for that is pediatrics, for pediatrics 70 plus 2 times the age. Okay, but again, even if they are pediatric, they still have to be able to follow directions and hold things up to their face. Anybody with an altered mental status, obvious intoxication, head injury, anybody with a chronic lung disease, whether it's COPD, asthma, or something like that, anybody with a suspected pneumothorax, we don't want to give nitrox or nitrous oxide to, anybody with a suspected bowel obstruction, anybody that has or is working through decompression sickness, coming back from a diving or submersion incident. All right, and then please remember the severity of pain must be documented for all painful conditions, as well as documented pre and post analgesic intervention. All right, so scale of 1 to 10, 1 being no pain, 10 being the most pain that this patient has ever experienced. So document that pre and post on all of your patients. So non-traumatic pain management, statewide AEMT protocol number 7003I. As you're giving any medications, please ensure that the oral medication is not contraindicated on your patient. Please remind to put your patient in a position of comfort. Provide verbal reassurance. And if they're mild to moderate pain, we can go ahead with the acetaminophen, typically for the adult at 650 milligrams orally. For your pediatric patient, make sure you see the pediatric dosing chart. For aspirin, we're going to give 324 to 650 milligram orally for an adult that is greater than 14 years old only. Or you can go ahead with ibuprofen, 400 milligrams orally. For any pediatric that's greater than 2 years old, see your dosing charts. Okay, but also please, again, remember, please don't administer these meds if the patient has had the same med recently within 4 hours for acetaminophen, aspirin, and within 6 hours if you have any NSAIDs. All right. Also, nausea or any contraindication to oral medication, again, put them in a position of comfort, verbal reassurance. Start an IV, IO of normal saline. If nauseated, consider ondansetron or your Zofran if administered. And if you do have nitrous oxide, you may want to go ahead and consider that if available. So stroke 7006, the update on this one, please make sure that you're familiar with the DOH's listing of recognized stroke centers. Here you could go to this website here, and this website, unfortunately, as I'm trying to come out of my PowerPoint, it would not let me do that, so I apologize. But again, you can go and click on that and go to that and find out where your recognized stroke centers are throughout the Commonwealth. You should transport to the closest certified primary stroke center, but if not, if the patient can arrive at the stroke center within 45 minutes, otherwise transport to an acute stroke-ready hospital if that patient can arrive at the facility within 45 minutes. If your patient will arrive to the ED within 3 hours of symptoms, initiate a second IV with a saline lock and route to the hospital. All right, so please be aware of where you live and where you're responding to. That way you can get your patient to the closest appropriate facility in a timely manner. If you do suspect a stroke, please utilize your Cincinnati Pre-Hospital Stroke Scale, also known as the CPSS, which looks at, also known as the FAST assessment, FAST, which means is there facial drooping present? any upper arm extremity or drift, and that's arms out, palms up. Upside down Superman, imagine that. Speech, do they have the inability to say that the sky is blue in Pennsylvania normally? Finding out when their last known well time was within the last 24 hours. That's very important. That will drive the stroke team wherever they are going to, drive the stroke team on different different treatment modalities, but again, it's one of those things you need to have a good last known well time and document that. With all of this, if you do have positive positive signs and symptoms of someone who might be suffering from a stroke, package them up ASAP, measure your glucose, and treat appropriately. If the glucose is less than 60 milligrams per deciliter, follow your altered level of consciousness protocol, 7002I alpha, and as we've talked about, transport to the closest primary thrombectomy capable stroke center as that. Please notify the receiving facility as soon as possible. Don't delay transport. Initiate your IV on their way. And if that receiving facility has provided you with a blood draw set, please go ahead and follow their protocol. If your service does not utilize that, then obviously that's not going to be an issue. But go ahead, notify them as quickly as possible. Get on with the command. Tell them what your assessment findings are. And that you'll be bringing in a stroke, and depending on which service and facility you go to, they will mark their own internal policy and procedures for a stroke alert in general terms. If they're not suspected of having a stroke at time based on your assessment, please make sure you do a glucose stick. If glucose is less than 60, once again follow your altered level of consciousness protocol, and then contact command, tell them that you are coming in with this, but also again tell them that you have completed a stroke assessment, the FAST assessment, and you did not see any negatives at that point. Nausea vomiting protocol 7010I, and this is a new one. You initiate your patient contact, and then you go back and refer back to 201. And if you do are going to start treating them under the nausea vomiting protocol, make sure you initiate your IV of normal saline. If it's a pediatric patient or not, go ahead and get, as a general rule of thumb, 20 mLs per kilogram of normal saline in a fluid challenge if you have a patient that is showing signs of tachycardia or hypotension. My apologies. Hypotension. And again, listen to lung sounds pre and post, but if your patient has any type of history of CHF or renal failure, you might want to contact medical command to find out if they do want you to go ahead with that fluid challenge. Consider drawing blood samples for nausea, vomiting. Again, just like as we were talking previously, if your service and or the receiving facility doesn't utilize those protocols, then no harm, no foul with that. So in these cases, does your patient have severe nausea and vomiting? No. Contact command, discuss treatment options. If they do, and they're less than age of 15, then you contact medical command. If greater than 1 year old, consider administration of your Zofran following these obvious treatment points, but utilizing your rubric down here on the patient's age and weight, and administering the approximate amount. If somebody falls in between, go ahead and contact medical command and ask their opinion in that. If your patient is greater than 15 years of age, administer your Zofran if you do have it available, 4 milligrams, and that can be given IM, your dissolving tablet, or slow IV over 2 to 5 minutes with that. Again, slowly 2 to 5 minutes, and then contact command, discuss what you did, and see if you've had any positive treatment reactions, maintaining vitals and everything else like that, and discuss with command whether or not you should continue the fluid challenge. But again, based on your assessment of what the patient is, listening to lung sounds and all, you should be able to make that decision. So If anybody has any questions, please feel free. You could contact me at the information at the beginning of this video, as well as in the course site. You could email me at richard_pearson@lemsa.com, or you could call my cell or text me at 717-874-0187. Now, once you have successfully completed all 3 modules, we will then be scheduling at a later date and time and location for your skills review in relation. There will be scenarios. We'll go into a little bit further medication review, and then we'll have skills and demonstrations for all of the information that has been presented to you in these 3 videos. So please proceed to the quiz that's related to part 3. Remember, you have to have 80% or greater required to continue, and then I'll be sending out emails as far as when the skill sessions will be being offered. Thank you again for listening and watching and updating yourself to the new standards. Please be mindful that this video was started pre-COVID, and now here we are ending post-COVID, so things have changed. But again, I congratulate you on your success as an AEMT, and look forward to working with you all in the future. Thank you. Have a good night and be well.